Imagine stepping into an oncology ward where the tumors are growing like 10, maybe sometimes 20 times faster than the cancers you normally see in adult patients. I mean, the proliferation rate is just terrifying.
It really is, yeah.
But then the overall cure rate for these incredibly aggressive diseases is actually dramatically higher than it is for most adult solid tumors.
Which is wild, right? It's one of the most fascinating contradictions in medicine, honestly.
Totally. So today, we're unpacking that exact clinical paradox. We're going to look why a catastrophic error in a child's cellular blueprint actually makes them, uniquely equipped to beat the disease.
Right. And if you're listening to this, like maybe you're a medical student prepping for boards or a young clinician stepping into pediatric oncology for the first time, we're synthesizing the core principles from the 7th edition of the Oxford Textbook of Cancer in Children.
Yep, the ultimate deep dive.
Exactly. We're moving way beyond just memorizing protocols. We really need to look at the underlying physiological mechanisms, the pharmacology, and how you actually apply evidence-based medicine when a child's life is literally on the line.
Okay, let's unpack this right at that paradox, because my instinct, just looking at the raw biology, is that a faster-growing tumor should be way harder to cure, right?
You think so, yeah.
So why is the exact opposite true here?
Well, to understand that, you really have to look at how adult and pediatric cancers actually originate. So adult cancers are often like engines that have slowly broken down over decades of wear and tear.
Like environmental exposures, smoking, that sort of thing.
Exactly. Smoking, cellular aging, they've acquired these really complex overlapping mutations and resistance mechanisms over years. But childhood cancers, on the other hand, are typically an error in the initial blueprint during cellular construction.
Ah, so before the house is even built.
Right. They almost entirely have an embryonal origin. So they're composed of these primitive, undifferentiated cells that are just trying to build tissues rapidly.
So they're essentially just stuck in a loop of explosive, unregulated growth.
Precisely. And honestly, that explosive growth is their Achilles heel. I mean, cytotoxic chemotherapy works by targeting and destroying rapidly dividing cells.
Right. It looks for the active ones.
Yeah. And because those pediatric blueprint errors are proliferating so aggressively, they're incredibly hungry. They just take up the cytotoxic agents at a massive rate.
Wow. And that leads to the cell death.
Yeah, widespread apoptosis or programmed cell death, whereas the adult rested engine tumor, which might be growing quite slowly, it doesn't take the bait in the same way.
That makes a lot of sense. The biology is just fundamentally different, which actually explains something else I noticed while reviewing the demographic data for this deep dive.
Oh, the survival charts.
Yeah, I was looking at the survival charts, and there's a really stark, concerning dip in survival rates for patients right around their, late teens and early 20s. What is going on there?
Ah, yeah. You've spotted the AYA gap. So AYA stands for adolescents and young adults, which is usually defined as ages 15 to 24. And this group kind of falls into a dangerous clinical twilight zone.
Twilight zone in what sense, though? Biologically or systemically?
Honestly, both. Biologically, their tumors are transitioning, so a 19-year-old might develop a classic pediatric embryonal tumor
Or they might get an adult-type carcinoma.
Exactly. And systemically, they often fall through the cracks between pediatric and adult treatment centers. Like a young adult treated for acute lymphoblastic leukemia by a pediatric oncologist on a pediatric protocol. Historically, they have significantly better outcomes than the exact same aged patient treated by a medical oncologist on an adult protocol.
Wait, really? Just based on the ward they're in?
Yeah, the protocols are that different. Plus, clinical trial enrollment for this specific age group is historically just abysmal.
Because they don't cleanly fit the International Classification of Childhood Cancer, the
Right.
ICCC3, but they aren't fully adults either.
That plays a huge role, yeah. Pediatric cancers under age 15 are classified primarily by their morphology.
Right, what the cells actually look like under a microscope.
Right, whereas adult cancers are classified by topography, where the tumor is located, like breast or lung. So AYAs straddle those two completely different worlds.
Okay, so if we know we're dealing with a fast-growing embryonal tumor in a child, we obviously need to find it and define it immediately. But, if I'm a resident and a child comes into the ER with a suspected abdominal mass.
You want to scan everything.
Exactly. My reflex is to want the highest resolution image possible. I will put them right in the CT scanner. But the textbook pushes back on that reflex pretty hard.
It has to push back. I mean, the radiation burden from a CT scan is a massive factor for a developing child. Their tissues are highly radiosensitive.
Right, you're introducing radiation to a body that's rapidly dividing its cells anyway.
Exactly. You always have to remember the principle of ALARA as low as reasonably achievable. So for any suspected abdominal or pelvic mass, the absolute first step is always a conventional ultrasound. It's completely radiation-free.
But can an ultrasound really tell you if a mass is malignant? I mean, isn't it kind of blurry compared to a CT?
It can give you critical clues, especially when you use Doppler ultrasound, because remember, tumors need a massive blood supply to support that rapid proliferation we just talked about.
Oh, right. So the Doppler shows the blood flow.
Yeah, by turning on the Doppler function, you can visualize the vascularity. If you see chaotic, high-velocity blood flow diving right into the center of a solid mass,
Then your suspicion for cancer skyrockets.
absolutely. That simple radiation-free step can often help you differentiate between a harmless, proliferating benign hemangioma and a highly malignant tumor like a neuroblastoma.
Wow. But surely we can't stage a complex cancer with just an ultrasound. Like there has to be a threshold where we just accept the radiation risk and use a CT, right?
Oh, of course. If you need to look at the lung parenchyma, the functional tissue of the lungs, to check for tiny millimeter-sized pulmonary metastases, you need a CT. Ultrasound just can't see through air.
Makes sense.
But here is a really critical mechanical difference you have to remember for your clinical practice. In adults, radiologists often run multi-phase contrast CTs. They scan before the contrast dye is injected, then during the arterial phase, and then during the venous phase.
Which means the patient is getting hit with 3 separate doses of radiation.
Right. But adults have visceral fat in their abdomen and retroperitoneum. And that fat provides a natural dark contrast against the brighter organs. Children, though, have virtually no internal body fat.
So everything's just kind of squished together.
Exactly. Because they lack that natural tissue contrast, doing multiple phases doesn't really yield much more information. So a single-phase contrast-enhanced CT is usually all that's required to separate the structures visually.
Oh, wow. So you get the same diagnostic yield for a fraction of the radiation.
Precisely.
Okay, so knowing when to use ultrasound versus a single-phase CT, that requires keeping up with the latest protocols. Which brings us to the actual application of evidence-based medicine, or EBM on the ward.
Oh, this is a huge topic.
Yeah, because I read a terrifying statistic in the textbook. It estimates that for a clinician to stay fully updated today, they would need to read about 17 journal articles a day, every single day.
Which is just not happening.
Right. Between rounds, charting, patient care.
Yeah.
That is physically impossible. So how do you actually practice EBM without just drowning in data?
Well, what's fascinating here is that true EBM is not about stubbornly reading every single isolated paper that gets published. You utilize hierarchies of evidence.
Hierarchies like the 5S pyramid.
Exactly. EBM defines 3 roles for a clinician: the replicator, the doer, and the user. The doer is the one running the primary research. The replicator is just blindly copying what their attending physician does.
And we obviously don't want to just be replicators.
Right. The goal for anyone listening to this deep dive is to become an efficient user of evidence. And users rely on that 5S pyramid.
Okay, so I'm familiar with the PISCO framework for asking foreground questions like population, intervention, comparison, outcome. But how does the 5S pyramid actually filter that fire hose of data?
It filters from the top down. So at the very peak of the pyramid are systems. These are integrated electronic care pathways built right into a hospital software, constantly updated by experts.
Oh, so it's baked into the tools you're already using.
Yeah. But if your hospital doesn't have that, you drop down a level to summaries. These are established, peer-reviewed clinical guidelines from major international groups, like, say, the Children's Oncology Group.
Gotcha. So you let the major organizations do the heavy lifting of synthesizing those 17 papers a day.
Exactly. Why reinvent the wheel? If there's no summary for a rare condition, then you drop down to synopses of individual studies, then syntheses like Cochrane systematic reviews.
And what about just reading a normal study?
That's at the absolute bottom of the pyramid. Only if you have exhausted all other options do you start digging through single, isolated studies. You always start at the top to save time and ensure you're using a validated consensus.
That is so practical. Okay, let's apply that. Say we've used our evidence-based care pathways, we've imaged the tumor safely, and we have a diagnosis. Now we actually have to administer the therapy.
The tricky part.
Yeah, because this is where the concept of treating a child like a mini adult gets downright dangerous,
Right.
right? Particularly with infants. Like if I'm calculating a chemotherapy dose, why can't I just use the standard adult Dubois formula, calculate body surface area based on height and weight, and just scale it down?
Because the underlying geometry and organ maturity of an infant completely invalidate that math. It's a huge pitfall.
Really? How so?
Well, an infant, specifically one weighing less than 10 kilograms or under 1 year of age, has a massive head and a disproportionately large body surface area relative to their actual internal mass.
Okay, but chemo is often dosed by surface area because it supposedly correlates better with cardiac output and metabolic rate, doesn't it?
In adults and older children, yeah, it does. But in infants' renal and hepatic clearance systems, their kidneys and liver, which are responsible for filtering and metabolizing these highly toxic drugs, they're functionally immature.
So they're basically not fully online yet.
Right. So if you use their artificially high surface area to calculate the dose...
Oh, I see. You're going to massively overestimate what their liver and kidneys can handle.
Exactly. You will cause a fatal overdose. The toxic metabolites will just build up in the bloodstream. So if you're prepping for your boards, lock this into your memory right now. For infants, chemotherapy dosing must be calculated strictly on body weight in kilograms, never body surface area.
Body weight only. Got it. But even if we calculate the weight perfectly, everyone's metabolism is still slightly different. So how do we ensure we aren't destroying the child's organs while trying to kill the cancer?
We rely on therapeutic drug monitoring, or TDM. This is the practice of drawing blood at very specific intervals to measure the exact concentration of the active drug in the patient's system.
Like tracking it in real time.
Exactly. Take a drug like methotrexate, which is crucial for leukemia. It has an incredibly steep dose-response curve and a razor-thin therapeutic window.
And if you get it wrong...
If the blood concentration stays too high for too long, it causes irreversible renal failure and severe mucositis. TDM allows the clinician to literally thread the needle in real time. We can administer rescue agents if the drug isn't clearing fast enough.
Wow, that is incredible precision. And it seems like that precision is moving beyond just traditional chemo, too. The textbook outlines some of the novel therapies, and the mechanisms are just mind-blowing.
Oh, the immunotherapy advancements are incredible.
Yeah. Can you walk through how something like CAR T-cell therapy actually works on a cellular level?
Sure. So CAR-T is a prime example of personalized immunotherapy. First, we extract the patient's own T cells, the soldiers of their immune system, right from their blood.
Okay, so you take the natural defenders out.
Right. Then we send them to a lab, and using a viral vector, we genetically engineer them to express chimeric antigen receptors on their surface.
And what do those receptors do?
They're specifically designed to recognize a unique protein on the surface of the leukemia cells. Once they're ready, we multiply these engineered T cells by the millions and infuse them back into the patient.
So they essentially become a living drug hunting down the cancer.
With devastating efficiency. It's brilliant.
It really is. And we're also seeing epigenetic agents now, like HDAC inhibitors. From what I understand, they don't even kill the cell directly. They actually try to reprogram it.
That's the beauty of epigenetics, yeah. Cancer cells often silence their own tumor suppressor genes by tightly coiling their DNA around proteins called histones.
So they hide the protective genes, making them unreadable.
Exactly. But HDAC inhibitors, like vorinostat, they block the enzyme that keeps the DNA coiled. So the DNA unspools, the tumor suppressor genes become readable again, and the cell essentially remembers how to regulate itself.
Or it undergoes apoptosis.
Right. We're literally hacking the cell's operating system.
Wow. But despite all these molecular hacks, we still rely heavily on physical interventions, like radiotherapy, for solid tumors. But irradiating a growing child comes with a terrifying cost of cure, doesn't it?
It absolutely does. I mean, a child's bones are actively lengthening at the growth plates. Their brain networks are rapidly forming.
Right, they aren't static like adults.
Exactly. If you irradiate a developing spine, you don't just stop the tumor, you stop the bone from growing. That leads to severe skeletal asymmetries. If you irradiate the brain, you risk profound cognitive deficits, endocrine failure, and a very high risk of inducing secondary malignancies decades later.
Which is why there's such a massive push for adaptive radiotherapy.
Yes. Adaptive radiotherapy means we don't just create one radiation plan on day one and blindly use it for 6 weeks. As the chemotherapy shrinks the tumor actually pulls away from critical healthy organs.
So the target is physically moving and changing size.
Right. So we constantly reimage and replan the radiation fields to shrink the target volume. This ensures we're only hitting the remaining cancer and sparing every possible millimeter of healthy tissue.
The coordination required for that is staggering. And, none of these advancements, the SAR T cells, the epigenetic hacks, the adaptive imaging, none of it exists without clinical trials.
True.
But running a trial on a pediatric population presents a massive ethical dilemma, doesn't it?
It's a huge hurdle. In adult oncology, a phase I trial is usually a first-in-man study. The primary goal is simply to find the maximum tolerated dose of a brand new molecule.
So it's highly experimental, just pushing the dose until it gets toxic.
Yeah. But ethically, we cannot subject a child to an untested, potentially lethal chemical simply to find a dosing ceiling. Therefore, a phase I trial in pediatrics is almost always first in child.
Meaning the drug has already been extensively tested for safety in adult populations first.
Exactly.
Is there ever an exception to that rule, though?
The only major exception is when a drug is designed to target an antigen that is entirely unique to pediatric cancers. For example, the GD2 antigen is highly expressed on neuroblastoma cells, which is a strictly pediatric tumor.
So testing it on adults wouldn't even do anything.
Right. An adult safety trial wouldn't make any sense. So those target-specific therapies enter pediatric trials directly.
Okay, so assuming a drug passes phase 1, how do you even run a phase 3 efficacy trial? Because childhood cancers are incredibly rare.
Fair.
If you need 1,000 patients to prove a drug works better than the standard of care, but there are only like 50 kids diagnosed with that specific subtype in your country each year, the math just doesn't work.
It absolutely doesn't. And that's why international collaboration isn't just some bureaucratic preference. It is a mathematical necessity.
Yeah.
Major cooperative groups across continents have to pool their data.
Because if they didn't.
Without global enrollment, a single phase 3 trial could take 20 years to complete. And by that time, the science would be totally obsolete.
That makes sense. But speaking of the global landscape, this is where the textbook forces us to confront a really grim reality. The benefits of these international trials are super isolated.
Yeah, the disparity is heartbreaking.
In high-income countries, the overall cure rate for pediatric cancer is hovering around 83%. But in low-income countries, it's a devastating 7%.
And if we connect this to the bigger picture, that disparity is almost entirely driven by the availability of supportive care, not just the chemo itself.
I want to dig into that because the textbook outlines a strategy called adapted treatments, used in low and middle-income countries, or LMICs. The concept is that doctors in these regions intentionally use a less intense chemotherapy regimen.
Right.
From a purely biological standpoint, isn't that totally counterintuitive? If the goal is to cure a fast-growing cancer, shouldn't you hit it as hard as possible?
In a vacuum, yes. But you have to view the biology through the lens of infrastructure. A highly intense Western chemotherapy protocol is incredibly myelosuppressive. It completely wipes out the bone marrow, dropping the patient's white blood cell count to 0.
So they have absolutely no immune system.
None. In a high-income country, we rescue that bone marrow by administering drugs like G-CSF granulocyte colony stimulating factor.
Which forces the marrow to rapidly produce new white blood
Yeah,
cells.
exactly. Plus, we have sterile isolation rooms, broad-spectrum prophylactic antibiotics, and intensive care units. If a clinic in an LMIC lacks G-CSF, lacks clean water, and lacks ICU beds,
Then that intense chemo is basically a death sentence anyway.
right. It will successfully eradicate the cancer, but the child will die a week later from a common bacterial infection.
Wow. The cancer is cured, but the patient is lost.
Exactly. So clinicians in LMICs use a pragmatic step-up, step-down approach. They start with a baseline, low-toxicity regimen.
And then what? They just watch the outcomes?
Yeah. If they monitor their outcomes and see that toxic deaths from infection are low, they can step up the chemotherapy intensity to cure more of the primary cancer. But if toxic deaths spike due to a lack of resources, they step down the intensity to save lives overall.
It's just brutal triage. But how do they even know when to step up or down if they don't have the infrastructure to track complex data?
That's where global initiatives step in. Platforms like Resonance Oncology provide free, cloud-based data management specifically designed for LMICs.
Oh, so they can track outcomes and toxicities in real time.
Exactly. Additionally, there is a massive global advocacy push to ensure these clinics have access to oral morphine.
For pain management.
Yes, because if a cure is mathematically impossible due to a lack of supportive care, palliative medicine and severe pain control are recognized as a fundamental human right.
That really recontextualizes the work. Okay, I want to take all of these systemic principles we've discussed, the embryonal biology, the evidence-based staging, the risk of toxicities, and apply them to how we actually map out a surgical plan.
Let's do it.
The textbook highlights Wilms tumor, which is a pediatric kidney cancer. And there is a massive philosophical divide between the European approach and the North American approach.
No.
Why do two highly advanced groups treat the exact same tumor in reverse order?
It comes down to weighing the mechanical risks of surgery against the biological risks of altering the tissue. So the European group, SIOP, mandates preoperative chemotherapy for almost all patients over 6 months old.
Meaning they give drugs like vincristine and actinomycin D before any scalpel touches the patient.
Exactly.
What's the mechanical benefit of doing that?
Wilms tumor is often massive, highly vascular, and incredibly fragile. It can easily rupture during extraction. By giving chemotherapy first, the tumor shrinks dramatically.
Okay, smaller target.
Right. But more importantly, the dying cancer cells create a tough, fibrous capsule around the tumor. This makes the subsequent surgeries significantly safer and drastically reduces the risk of the tumor popping like a balloon and spilling millions of cancer cells throughout the abdominal cavity.
That makes perfect logical sense. Toughen it up, shrink it, pull it out cleanly. So why on earth does the Children's Oncology Group, COG, in North America reject that?
Because COG prefers pure data. Their philosophy is that the moment you introduce systemic chemotherapy, you alter the histological reality of the tumor.
You kill off certain cell populations and change the architecture.
Yes. COG argues that the only way to perfectly tailor post-operative chemotherapy, ensuring a low-risk patient isn't subjected to highly toxic, late-effect-inducing drugs, is to get a pristine, completely unaltered tissue sample.
Oh, I see. So they do primary surgery first.
They do.
So they basically accept a slightly higher risk of surgical rupture to guarantee accurate, unpolluted staging.
Precisely. And the fascinating part is that both approaches, while philosophically opposite, yield excellent overall survival rates. It just shows how evidence-based medicine can support different pathways depending on which risk factors a system prioritizes.
That is so interesting. That actually leads me to ask about the leukemias, because the textbook contrasts all acute lymphoblastic leukemia with AML acute myeloid leukemia. And the treatment pacing couldn't be more different.
Oh, they require entirely different mindsets. Treating all L is like trying to weed a massive garden by hand.
How so?
You start with multi-agent induction to aggressively clear the visible weeds and get into remission, but you know there are microscopic roots left behind. So you follow up with a grueling maintenance phase lasting 2 to 3 years of daily low-dose oral chemotherapy.
2 to 3 years, wow.
Yeah. The goal is to slowly, methodically eradicate every single microscopic trace of minimal residual disease.
AML.
AML is a controlled burn of the entire field. The treatment is comprised of short, incredibly intensive blocks of chemotherapy. It is highly myelosuppressive. It completely obliterates the bone marrow.
So the patient needs intense, life-threatening supportive care.
Exactly. But the overall duration of the therapy is much shorter than ALL. There is no multi-year maintenance phase. You burn it down, rescue the patient, and hope the marrow regenerates clean.
We have covered an immense amount of ground today, from the blueprint errors of embryonal biology to the lack of retroperitoneal fat-altering CT protocols to the precision of CAR-RT cells and the stark reality of adapted treatments in LMICs.
It's a lot to process.
It is. But before we wrap up, I promised a high-yield study session. So here's a quick clinical review question for you to test your retention right now. You are working the floor, and you need to write an order for an 8-month-old infant weighing 8 kilograms who requires cytotoxic chemotherapy.
Tricky scenario.
Right. Do you calculate their dose based on the Dubois body surface area formula or purely on body weight, and why?
You must calculate it based purely on body weight. Remember the physiology? Infants have a disproportionately massive body surface area and immature renal and hepatic clearance systems.
So if you use surface area...
If you use a surface area formula, you will overestimate their liver's capacity to process the drug, resulting in a potentially fatal overdose.
Keep that at the forefront of your mind.
Absolutely. And as we conclude, I want to leave you with a broader concept to ponder. As our molecular hacking and engineered T cells push pediatric survival rates past 80% in developed nations, our clinical focus must shift.
from simply curing the child.
Exactly. We're moving from simply curing the disease to managing the lifelong cost of cure, the cognitive deficits, the skeletal asymmetries, and the organ damage caused by the very therapies that save them.
Just a heavy thought.
It is. Are we inadvertently trading a fatal pediatric cancer for an adulthood plagued by severe chronic illness? And if so, how must your generation of clinicians adapt drug development to finally decouple efficacy from lifelong toxicity?
A really profound challenge to carry with you. As you head back to your wards, your clinics, or your board prep, review your notes and think about how these mechanisms dictate practice. When you see a pediatric case, don't just see a rusted engine you need to patch up. Look for the error in the blueprint and use every tool in the evidence-based arsenal to correct it. Keep questioning the standard of care, and we will catch you on the next deep dive.